Okay. Any dissenting? All right. Oh, I like that. You found the little thumbs up the option on the bottom. That's great. Okay. Yes, please go ahead. So I am very excited to be able to introduce Susan Hess. She is a licensed professional counselor in Colorado with a master's degree in transpersonal counseling, psychology, and music therapy from Naropa University in Boulder. Her extensive training in mindfulness, meditation, and compassion skills initiated her interest in supporting women with cancer. From 1998 to 2005, she facilitated weekly ovarian cancer support groups at a cancer wellness community. In 2005, she co-founded the Colorado Ovarian Cancer Alliance, or COCA, with a group of ovarian cancer survivors. At COCA, she expanded her work to 4 ovarian cancer support groups per month while acting as staff clinical supervisor and programs director of a range of ovarian cancer support services. Overall, Susan has facilitated over 1,000 ovarian cancer groups since 1998 and has spoken with many hundreds of women managing an ovarian cancer experience. So she comes with a great wealth of experience. In 2018, Susan began work at the Clearity Foundation, an organization in San Diego dedicated to improving the survival and quality of life for women with ovarian cancer nationwide. At Clearity, she joins a team of professionals tasked with designing an effective and accessible ovarian cancer psychosocial support program. In 2020, Susan became the program director of Clarity's Steps Through OC program, overseeing operations and a team of 10 OC counselors who provide telephone and video conference psychosocial support to survivors and caregivers nationwide. Her expertise, including working with issues surrounding cancer and illness, grief and loss, life transitions, stress management, cancer trauma, and post-traumatic growth, using mindfulness, compassion, expressive arts, and evidence-based counseling techniques. So with that, I'm very, very pleased to introduce and welcome Susan Hess. Some of you may already know her. I know Melissa, you and I both have fond connections with Susan, and if you're meeting her for the first time, you're in for a treat. So thank you, Susan, and welcome.
Thank you, Janice. That's really sweet. Yeah, and before I dive into the program, I just want to say that I was active in the Colorado Cancer Coalition for many years too, and was part of the Ovarian Cancer Task Force when there was a task force. And the way that the Colorado Ovarian Cancer Alliance, when we first got started, we submitted for a grant and got our first big grant from the CCC to go forward with our nonprofit. So I feel very good about this organization and everything that you're doing now and that has been done in the past. So, so as you may or may not know, September is Ovarian Cancer Awareness Month. Our color is teal. And so I'm going to give you an overview today of just the challenge of ovarian cancer. I'm going to go through a lot of details and statistics for those of you that aren't as familiar with it as a diagnosis, but I also hope to fill it in with a few of the experiences and stories and things that I have gained over the years. So next slide, please. So the first thing we're going to do is just look at some of the statistics of ovarian cancer. So next slide. So first of all, it's the second most common gynecologic malignancy behind uterine cancer. And in 2020, it's estimated there will be 21,750 new cases and around almost 14,000 deaths. Next slide, please. And the overall survival, the overall 5-year survival rate is 48%. So it's less than 50%. And it ranks as 5th leading cause of cancer death in women in the US. And it has more cancer deaths than any other reproductive cancer. So it's a real challenge when less than half of the women who are diagnosed survive longer than 5 years. Next slide, please. The lifetime diagnosis risk is 1 in 78. So it's not nearly as common as breast cancer, which I think is somewhere closer to 1 in 8. So it's 1 in 78, but it's still fairly common. It's considered a little rare, but we certainly have plenty of women in our organization dealing with it. And next slide, please. And most women are diagnosed between 55 and 65 years old with a median age of 63. However, this can be a little misleading because there are definitely women in their 40s and 30s and 20s, and there's even teens and young adults who can be diagnosed with ovarian cancer. So for quite a while, it was kind of considered an older ladies, older woman's illness, but I've known many women that are younger who wound up getting diagnosed because the doctors really weren't thinking about it being something that they would be susceptible to. So I think we can say that there's that median age, but we have to remember that that's not everyone. It's just a median. Next slide, please. And then it's most common in white women per 100,000. It's most common in white women, then non-Hispanic white women, and then Hispanic, and then Asian Pacific, and then Black, and then American Indian. And what's interesting about this is when we get into the part about risk factors and about risk factors and the BRCA mutation, that the Hispanic women are also really susceptible to this, as well as they are to breast cancer, as well as then, of course, the Jewish community, Ashkenazi Jewish community. So, but we'll talk about that a little bit more. So it really is highest in white women, but and then it goes down from there. And next slide, please. So the key is, so it's stages 1A and 1B, which is confined to the primary site in one or both ovaries, just in the ovaries. At stage 1, there's a 92% survival rate, but only 16% of women are diagnosed at stage 1. And I will get to this again too, but I'll say it a few times. There is no screening test. So there isn't really a way to find it. So stage 1 it's very survivable, but not many women are diagnosed there. Next slide, please. If I can do mine here, right. So at stage 2, we're looking at a lower survival rate, 74.8, but still a pretty low percentage diagnosed at this stage. So still not, it still isn't a really, it's an okay survival rate, but not the greatest. And then when you go to the next slide, please, this is, most of the women are diagnosed at stage 3 and 4. It has metastasized at some point. Stage 4 is outside of the peritoneal cavity. So 58% of women are diagnosed at stage 3 or 4, and there's only a 30% survival rate. So it's really a challenging illness. And most of the women that I've met were diagnosed at stage 3C. So they have this 58% survival rate that, 58% were diagnosed at that 30% survival rate. So they're really dealing with something very challenging, both physically and mentally, emotionally. Okay, next slide. And then if we look at, if there's an unknown stage, then 5% are diagnosed there, but at an even lower rate, at a 25% survival rate. So next slide. So ovarian cancer death is highest in women, again, around 70. I would also have that caveat where, again, there are younger women who are dealing with this who have died from this diagnosis. But there is this still general age around 70. And next slide, please. The lifetime risk of death is 1 in 108. And then next slide again. This is the death rate is highest again in white women, but I think we can then see that it goes to non-Hispanic and then Native American, Black, Hispanic, and Asian Pacific. So I think there may be some disparity in there as well. Not just this, because it doesn't match up exactly with the diagnosis rate. So next slide then. Just a call out to uterine cancer, that it is the most frequently diagnosed. And then there's the other gynecologic cancers, fallopian tube, cervical, vaginal, and vulvar cancers. And then primary peritoneal cancer of the peritoneum is usually lumped in with ovarian cancer. It's treated the same way. So in the community of women with ovarian cancer, usually women with primary peritoneal as well. So next slide. And just a quick, just to make sure that we all know what we're talking about here, we're all on the same page. Knowing our female anatomy, that the fallopian tubes are attached to the ovaries. And then of course there's the uterus in the middle and the cervix at the bottom of the uterus, and then the vagina, and then the vulvar is the external organs. So when we're talking about this, there's been, and there's another slide I'll talk about, but how fallopian tube cancer is also related to ovarian cancer. Uterine cancer is sometimes called endometrial cancer because of the endometrial lining inside of the uterus. And so, just so we all remember what female anatomy is really like. So next slide, please. So let's talk a little bit about symptoms. Next slide. So it can take a really long time for a woman to get diagnosed with ovarian cancer. My sense is, and I'm not a doctor, but that the ovaries are really deep in the body. So usually the symptoms aren't experienced until they're pretty advanced. They're not, women start having some of these symptoms, but sometimes they're just not caught early. Next slide, please. And the symptoms, the four kind of main symptoms that were agreed upon by a group of gynecologic oncologists around 2012, I think it was, are bloating, the sense of abdominal bloating, pelvic or abdominal belly pain, trouble eating or feeling full quickly, which goes with the bloating. Women often feel the bloating and then they feel like they can't eat very much. They just can't really hold down a very big meal or a lot of food. And then urinary symptoms such as urgency and frequency. These are the four agreed upon main symptoms, but as we can tell, these are also symptoms that women who are around age 60 to 70 have anyway, often. So this is where they can go in and say, I have these symptoms, and they can be misdiagnosed. We'll talk about that in a little bit more too. Next slide. Some other symptoms are fatigue, which we see with other cancers as well. An upset stomach, back pain, pain during sex, constipation, changes in a period, and abdominal swelling with weight loss. Generally with ovarian cancer, there isn't a whole lot of bleeding. It's mostly, or spotting, it's mostly this bloating that seems to be the biggest and most common symptom that so many women experience. It's with uterine cancer that there can be, but it shows up with ovarian cancer at times too. But certainly those first four show up very frequently. So next slide, please. So, here's the bottom line, that women can experience these symptoms as vague, this abdominal pain, bloating, feeling full quickly, change in bowel or bladder habits. And she might ignore them thinking, well, I'm just getting older. I'm just putting on a little extra weight, attributing them to other causes. But what's hard is that sometimes doctors and gynecologists also frequently overlook these symptoms, especially in younger women, and the risk factors, and misdiagnose it. So in my years with doing all the support groups, there was plenty of women, that would come in and say that they went to a gastroenterologist for gastro symptoms for, like a year before they got diagnosed with ovarian cancer, and thinking that it was irritable bowel syndrome or something like that. Of course, because it's deep in the body, it can affect the bowel. So this whole misdiagnosis thing, and then younger women who the doctor's like, well, it certainly won't be ovarian cancer, but then it winds up being that. So it's been a challenge, I think, for years and years, that I think it's getting a little better, that these symptoms are getting out there and women are understanding, what these are, and making sure and getting them checked out, and more doctors are doing a little bit more digging to find out. Next slide, please. And then also making sure that checking somebody's risk factors before as they're, looking at symptoms and trying to figure out what's going on, because ovarian cancer is part of the HBOC syndrome, hereditary breast and ovarian cancer syndrome. So up to 25% of ovarian cancer cases are part of a family cancer syndrome. So what, as you know, if anybody that's really familiar with the breast cancer community, same thing. It's in the germline, it's a germline mutation, BRCA1 or BRCA2 mutation. And for ovarian cancer with BRCA1, there's a 35 to 70% lifetime ovarian cancer risk. And then with BRCA2, it's a 10 to 30% by age 70. And about 10 times more common. Oh, was the question there? Oh, about 10 times more common in those who are Ashkenazi Jewish than those in the general population. And also, because of that BRCA mutation having migrated from Eastern Europe into Spain and then into Mexico and then into in New Mexico and southern Colorado, there can also be a higher incidence of ovarian cancer in the Hispanic community, like in San Luis Valley. And the guy that wrote the book about the Indian princess and the wandering gene, Jeff Wheelwright, a very interesting book about this, the prevalence of the BRCA gene in our state and in the Hispanic community. So we just all want to be aware of that. So those, so a doctor, it's good for a doctor to know that if a woman has these symptoms, that also could indicate a risk factor for ovarian cancer. And next slide, please. And then again, there's the other genetic syndromes like Lynch syndrome, the abdominal, that abdominal mutation or mutation within that shows up as abdominal cancers. Then several different genetic mutations that can show up in an ovarian cancer diagnosis. And then there's just the general family history and a personal history of breast cancer, even without the genetic component, can be a risk factor for ovarian cancer. So next slide, please. And then some of the other risk factors that there is out there. I know you're not seeing. Hopefully you are seeing my source links at the bottom of the page. All right, I'm not seeing them so well, but so that you know that these are all coming from. This one's from American Cancer Society, but so unexplained infertility, obesity, nulliparity with no childbirth. This fourth one, use of estrogen over a prolonged period of time, that's been very controversial, but the question of whether HRT can be a risk factor, and then smoking. So these are just other things to keep in mind in terms of risk factors. So next slide, please. And next slide. So we'll look at diagnosis. So the main thing that I already mentioned is that there is no screening test for ovarian cancer. A pap smear detects cervical cancer. And my colleagues here in Colorado at the Colorado Ovarian Cancer Alliance, we went out, and they still do, go out to the 9 health fairs every year, although I guess they probably didn't happen this year. And it was really surprising the number of women we would hand out a symptom card about ovarian cancer and say, we want to make sure that you know the symptoms of ovarian cancer to be aware of it. And they'd say, well, I go in for my pap smear every year. And we'd say, well, that doesn't check for ovarian cancer. It only checks for cervical cancer. The other challenge too is that many women would say, well, I've had a hysterectomy, but the standard of care for many years, and I'm not sure exactly how it's going right now, Melissa would probably know better, but that in some surgeries, that the ovaries are left in. So many of these women, there are many women that were in the support group that had ovarian cancer that had already had a hysterectomy for many years, but they still had their ovaries. So they were still at risk, and then they got ovarian cancer. So just some of those kinds of details to know. Next slide, please. And then, like I said earlier, by the time a woman goes to the doctor, it's often metastasized to stage 3C. And that's the most common stage of diagnosis. So next slide. So the way that ovarian cancer is found, if those symptoms start showing up, then what we want women to do is to go into the doctor and get a transvaginal ultrasound, and which is not really that invasive. It's a good, pretty easy test to have. have a CA-125 blood test taken to see if there's any sort of indication on that blood test. And then if there are indications there of any abnormalities, then the next step is to get a CT scan. Now, they don't use the CA-125 as a diagnostic tool because they feel like it is not accurate enough. It's similar to a PSA test, a prostate test, but there are definite false negatives and false positives. So it's still pretty much used just in the case of trying to find out if something's going on. But there are certainly women with a low CA-125 who have it, and women with a higher CA-125 who aren't diagnosed. So it's really this three-step process: the transvaginal ultrasound, the CA-125, and then a CT scan. Next slide, please. And then if there is an indication that there is ovarian cancer going on, the critical point is to make sure the woman is referred to a board certified gynecologic oncologist. And this is a really, really critical point, that there are a lot of gynecologists who are working out there that may encounter something unusual, but it's not the best scenario if they go ahead and start trying to figure out further what's going on. A board certified gynecologic oncologist is the person, is the standard of care, and that doctor can do an optimal debulking surgery, which requires a lot of skill and training. So next slide, please. So it is a fact that patients whose tumors have been optimally debulked have a better outlook than those who have larger tumors left after surgery, which is called suboptimally debulked. And next slide, please. And I was told once by Susan Davidson, who is a gynecologic oncologist at the University of Colorado for a long time. I said, what is it exactly about a gynecologic oncologist that I need to be able to tell the women in the group? And she said, the main thing is that we are really trained to stay in the body for a really long time, which allows for removal of as much disease as possible to do an optimal debulking. And then since gynecologists can also perform reproductive organ surgery, they are not trained to stay in the body for a really long time. So what can happen is they'll go in and do the initial surgery, but then, they can't really take care of everything. So then the woman does get referred to a gynecologist, and then they may have to have a second surgery. So it's just, again, really critical to know that we want all women who are dealing with ovarian cancer to get to a gynecologist. All right, next slide. And then, of course, in the surgery, a tissue sample is taken during the surgery, and then that frozen section is a frozen section. They make an initial diagnosis from there, and then the later in-depth pathology report shows the definitive diagnosis of ovarian cancer. So that's another piece, is that, it's really important for women to know that there may be a possibility of ovarian cancer, and it looks like it from from the diagnosis and from the tests and the CAT scan and all, but until the doctor actually gets in there and goes in there and gets a pathology report, it isn't a definitive diagnosis. So we definitely have had some women that said they did, and then after their surgery, they found that they didn't have ovarian cancer. So next slide, and we'll go through these quickly. Our time frame, Janice, is I need to be done when? I'm not hearing you.
We typically aim for about 30 minutes, so about 3:30, but I know you get started a little bit late, so you've got about 5-7 minutes.
Okay.
If that's reasonable for you, and allowing some questions. Yeah.
Yeah, I think I can go through this pretty quickly then.
Okay.
So the cell types, there are several different kinds of cell types of ovarian cancer. We won't really spend a lot of time on that, but epithelial cell type, which is the surface layer of the ovary, is the most common. And then out of that, there are 5 different epithelial cell types, and some of them are more aggressive than others. And next slide. Again, we talked about primary peritoneal, and then sometimes within the ovarian cancer world, fallopian tube cancer, like in the programs that we provide, fallopian tube is included because research began to identify that more than 50% of ovarian cancers originate in the fallopian tubes. So it starts there, and then they surround those ovaries. So it winds up becoming a cancer of the ovary as well. So next slide. The somatic mutations, while there are germline mutations of BRCA, there are also BRCA mutations in a somatic test of the tumor. So the Clearity Foundation, where I work now, was really insistent on helping women get a tumor profile, so that to see what was going on in the cells in the tumor itself, and see what somatic mutations were taking place there. So they're different than the germline hereditary mutations, and with that kind of information, it can be treated a little more targeted, with more targeted treatment. The surgery, next slide, please. There's often neoadjuvant chemotherapy before the surgery if there's a lot of bulk, a lot of tissue, that cancer tissue that's going on. So many women will have neoadjuvant chemotherapy, then they'll have a debulking surgery with their gynecologic oncology surgeon, and then they'll do the primary staging at that point. Next slide. And I think it's just important to remember that some of the implications for women then having the surgery is they might have a bowel resection, their omentum, the lining of their peritoneal cavity might be removed, their cervix might be removed, and the surgery can also reduce the size or the length of the vagina. So their sexuality, their sexual health gets impacted. So it's really important to know that pelvic floor rehab or sex therapy professionals can be really helpful in assisting women with both the physical and emotional healing of what goes on after a reproductive or ovarian cancer surgery. Next slide. And then there's just a standard of care with chemo. It's usually a carboplatin Taxol doublet. Almost every woman gets this. It's the standard of care. There can be different ways of doing it with the Taxol, maybe intraperitoneal. But I think the key of this slide is just that the standard of care hasn't changed for many, many, many years. Although now there's a couple of introductions of Avastin into the treatment, and then PARP inhibitors have been the latest best thing that's happened to ovarian cancer in the last decade, and they are really targeted toward women with the BRCA mutation, but the standard of care has been very similar for a long time. Next slide, and just the same, what we all know pretty much in terms of side effects: fatigue, hair loss from the Taxol, peripheral neuropathy from the Taxol, and then nausea, although that's usually pretty well managed. But the bowel issues are pretty big in ovarian cancer because it's right there around the whole bowel, and hair loss is always something for women, so it's helping women through that part of the experience as well. Next slide. So a woman goes into remission. If she does find a remission, then it's every 3 months. She has a checkup every 3 months for 2 years, and then every 6 months for 3 years, and then it's considered in remission after 5 years. And then regular checkups and scans after that. But women really do feel like a ticking time bomb because of this level of recurrence. Next slide, please. And then the next slide after that. So like we said earlier, women in stage 1 have a 10% chance, women in stage 2 have a 30% chance, but in stage 3 and 4, the 70 to 90% chance of recurrence. So they're just really, really anxious about this diagnosis. And even if they get to a good place at the end of treatment, they're really, really worried about what's going on. And this is a lot of why we have these interventions coming in, because these women are constantly worried about it, or they get a recurrence really quickly. So next slide. And part of this is because there's a platinum resistance, they get resistant to the carboplatin. And if they have platinum resistance, then they usually recur within 6 months after the end of their treatment. And it's just devastating for them. And then they have to figure out what to do next and what's the next best way to treat this cancer. If they're platinum sensitive, then they usually go longer than 6 months, but they still might recur at a year or 2 or 3 or whenever. And I've known women who've been in remission for several years and still had another recurrence. So this is one of the real challenges of ovarian cancer, is the recurrence rate. So next slide, please. The tumor testing is the Clearity Foundation, again, was, I'll talk about that here in just a minute, but checking out the somatic mutations in a tumor molecular profile is really one way to target what's going on, see what's going on, and be able to target the chemo, and then addressing the psychological impact of having this recurrence fear hanging over one's head all the time. That's why we intervene with this Steps Through OC program. And then next slide, please. Generally, symptoms near end of life are ascites. It's the bowel obstructions that can really cause a lot of problems of pleural effusion, bladder obstruction, and disordered nutrition. So it's just a hard diagnosis. But the women I know that have gone through it, have been real champions in so many ways. So let's just wrap up then with some info and support. And then next slide. So there are some major national organizations: Ovarian Cancer Research Alliance, National Ovarian Cancer Coalition. They're the two main national organizations. Next slide. Share Cancer Support out of New York provides peer mentoring for women with ovarian cancer with women with ovarian cancer. And then of course, FORCE, Facing Our Risk Empowered of Cancer. Empowered is for previvors and women who maybe want to get a hysterectomy when they're done with their childbearing years, to make an oophorectomy and get their ovaries out, to make sure that if they're at high risk. Next slide, please. Sharsheret is an organization especially for women, Jewish women with breast and ovarian cancer. And then Gilda Radner famously passed from ovarian cancer, and there's a cancer registry in her name. And then next slide, please. Foundation for Women's Cancer and Society of Gynecologic Oncology are both part of this community. But I want to just, next slide, wrap up with Colorado Ovarian Cancer Alliance, my alma mater. I helped co-found this wonderful organization. In Colorado, COCA provides a lot of services, and including financial ways to get financial assistance and support groups, individual support, comfort kits, has a big race every year. So if you know anybody in Colorado who's dealing with ovarian cancer, COCA is the place to go. And then Sue's Gift is down in Colorado Springs, and they are also a really wonderful ovarian cancer organization, good friends of COCA, and I know Sue DiNapoli very well. And so I really encourage that, if for women in Colorado. Next slide, please. But the Clearity Foundation, where I work now, and next slide after that, was founded by a biomedical researcher. Her name is Laura Shaver, and she was doing biomedical cancer research when she was diagnosed with ovarian cancer. So this organization was initially really founded on helping women make treatment decisions, looking at making sure women got a molecular profile, and then looking at that and having a big, long, good conversation with someone who knows a lot about it, and then being able to take that back to their doctor and making a decision, especially around recurrence, because that's when it becomes a real art and science of what to do next. And I'll never forget Laura Shaver saying it's kind of like throwing a dart at a dartboard. Unless you do a molecular profile, then you can find out what's going on with some of these mutations. And then next slide, please. We really strive to improve the quality of life with women with ovarian cancer. We offer individual support, education resources. There's no charge to participate in the programs. And then the psychosocial support program, Steps Through OC, we founded in 2018, and it was originally created as a virtual support with a one-on-one with a mental health professional or experienced master's level professional who can really help a woman go through the real challenge, the emotional challenge, with 10 sessions over the course of 6 months. So next slide, please. The Clearity programs both connect professionals with individuals remotely, by video conference or phone. Next slide. Treatment decision support. Patients make informed decisions with their physicians. Next slide. Steps Through OC provides 10 individual meetings over 6 months with a professional OC counselor. Next slide. We talk about, with the counselor, we have a phase model that talks about crisis of diagnosis, coping with treatment, transitioning to a new normal, and managing uncertainty as part of what we really help women go through, how we support them through the ovarian cancer experience. And then last slide, please. So questions. So that was a lot of pretty detailed information. If you want more information about our support programs, please feel free to contact me, and even Janice. You can ask Janice because she's working with us now too. Any questions?
That was wonderful. Yes, a lot to think about. Does anyone have a question that they wanted to ask Susan? And if we're not able to get to them all, I can collect them and pass them on to her, and we can still get back to you with responses as well. It was very thorough.
I don't have a question, but I do want to say real quickly, just the power of community in the cancer world and in survivorship. I don't use this word lightly, but Susan is one of my heroes for the work she's done with ladies. I met her when I was in general gynecology, and she was really one of the people that helped get me into survivorship and build the survivorship program. And so through our connections with coalitions and task force like this, we just see how we help each other. We're stronger together. So Susan, thank you not only for your time today and your work with so many of our ladies and patients, but just what you do and how that legacy is passed on. We thank you very much.
Yeah, thank you, Melissa.
Yeah.
That's sweet of you.
Very, very true. I have one quick question, and maybe it won't have a quick answer, but I see lots of ads about women and talcum powder and that relationship, but I didn't see a reference in your slides, and I'm wondering if there is something to say about that.
Well, you know, I think that at least I know through Clearity and through the COCA that, you know, there's all these lawsuits about it and women getting paid, and one of the first ones did pay out on that. I don't know that well, they're saying that there is a connection between them and that there was possibly talcum powder or asbestos found within an ovarian cancer tumor. But I would think, I mean, so there's still, the jury I think is still really out whether there's a really direct connection, even though these lawsuits are pulling out some of this research, so to speak. What my question is with that is, why wouldn't it cause vulvar cancer? I mean, you know, if talcum powder is being put on topically on the outside, why wouldn't it create cancer there rather than all the way up into the interior of the body, all the way into an ovary? You know, that's quite a ways for it to go. So
It's immaculate infection.
The what?
Immaculate infection.
Right. So you know, women ask about that, and they do call and ask and say, what about that? And usually what we say is, if somebody's interested in finding out about that. And Melissa, do you have anything else to say about that?
I think it's just safe to say the jury's still out. It's a big debate, you know, right. So it's still not clear.
Right. It has not been confirmed that it is a cause. So, but if I know that you know, what I have found is some caregivers, like a husband, if their wife has died and they're like, well, was that the cause? And they really want to find a reason why this all happened. And so they may be really curious about finding out about the legality of it, or the suit, and filing suit about it. But we don't really go there too much.
All right. Well, good to know. I appreciate that clarification. Once again, thank you so much, Susan, for joining us. You're welcome to stay for the business portion, or you can log off. That's perfectly fine. And for all of you participating today, if you have other questions, you will see the slides on our task force page, and along with the contact information for Susan. So you can either send those questions directly, or you can send them to us and we will relay them to Susan and make sure you get those questions answered. So thank you again.
And I have another meeting, so I will have to go.
All right. Wonderful. Thank you so much. Thank you.
Bye-bye.
All right. So let's take a look at the agenda.